Our next topic is the spinal cord. And so we've been going through our neuroaxis here, starting with muscle, working our way up. And so down here in blue, recall that neuromuscular junction muscle diseases have weakness without upper or lower motor neuron findings. Neuromuscular junction, classically it's fatiguing weakness with bulbar and ocular features. Muscle diseases, it's primarily proximal muscle weakness. Then we've been through all of these conditions in yellow, which have lower motor neuron findings. So remember, peripheral neuropathy, it's stocking glove, radiculopathy and plexopathy. We have focal weakness, focal sensory loss, focal reflex changes in whatever root or plexus distribution we're talking about. And if we have a pure anterior horn cell disease like polio or West Nile virus, we will have purely lower motor neuron findings. And then we did discuss Lou Gehrig's disease or amyotrophic lateral sclerosis, which involves anterior horn cells and also upper motor neurons. So that was really the first condition we've come to so far where we have upper motor neuron findings. But now as we get up to the spinal cord and move our way up to the cortex, we'll be seeing lots and lots of upper motor neuron findings. Because remember, our upper motor neurons travel from the cortex through the subcortical white matter, brainstem, and down through the spinal cord. So just looking at the spinal cord, here's a nice drawing here at T1, and we can see that we have these small, relatively unmyelinated fibers that come in at every level, here in red, along with the large myelinated fibers. And recall that the smaller fibers here contain information about pain and temperature. And so as this comes into the dorsal horn, there's a synapse right here at the substantia gelatinosa, and then it crosses over. And again, we're just arbitrarily here, this is a section at T1, and so that pain and temperature information is going to enter here, this medial portion of the spinothalamic tract, and then ascend. Whereas vibration and proprioception, there's no synapse, and it goes right up here through the posterior column. So notice that for the posterior columns, the sacral fibers are medial, and then we have the thoracic, then lumbar, and then thoracic, and then finally, if we get up to the cervical level, we'll see cervical fibers out here most laterally. Okay, the corticospinal tract is located here, and notice it has the same columnar arrangement as the spinothalamic tract, with the sacral fibers lateral, then lumbar, then thoracic, and if we look higher up, we'll see cervical fibers here. There are other upper motor neuron pathways that travel through this portion of the spinal cord, but for this review I've decided not to cover those. Out very laterally here we have the dorsal and ventral spinocerebellar tract, which is conveying information about the position of the extremities to the cerebellum. Okay, in the ventral horn we have our anterior horn cells, which remember are the lower motor neurons. And then a unique nucleus that we see from T1 to L2 is Clark's nucleus, and this is the relay nucleus, so information that will become the dorsal spinocerebellar tract. It travels up through the posterior columns, synapses in Clark's nucleus, and then moves out to the dorsal spinocerebellar tract. So when we get to the cerebellum, I'll explain this in a little more detail. And so here's another section higher up in the cervical cord, and the only difference here is, notice in the posterior columns, now we can see the cervical fibers here laterally. In the corticospinal tract, now we can see the cervical fibers medially, and in the spinothalamic tract, we see the cervical fibers medially. So very quickly, the corticospinal tract, very important upper motor neuron pathway, which I won't go over in detail here, just to mention it crosses really at the junction between the medulla and spinal cord. So any lesion of one half of the brainstem, subcortical or cortical, here on the right side, will result in contralateral, or in this case left-sided weakness, whereas any lesion on the left half of the spinal cord will give the patient ipsilateral weakness. And so remember that the leg fibers here in red come from the more medial portion of the cortex. And so if we follow this down, the whole corticospinal tract goes through the posterior limb of the internal capsule. That will be really important, as we'll see later. And we'll later on talk about where it travels through the brainstem, but then crosses over in the lower medulla and travels down as the corticospinal tract. So for the leg fibers, this is going to go all the way down to the lumbosacral cord, where it will activate appropriate anterior horn cells to move muscles. The face and arm fibers are more lateral, so here in blue would be for the arm, and again through the posterior limb of the internal capsule, and in this case talking to anterior horn cells in the cervical cord to move your arm and hand. Okay, and just because we mentioned it last time, the corticobulbar tract, which remember goes from the cortex to the bulb or the brainstem, and here we can see this traveling right along with the corticospinal tract, but now to innervate cranial nerve motor nuclei on the opposite side. So here it's only shown in the pons, so supplying the motor nucleus of the trigeminal and facial nerves. All right, here's the spinothalamic tract, which I just showed you a cross-section of. So remember, this is pain and temperature that's entering, and it ascends for a segment or two in Lissauer's tract. Then it synapses in the substantia gelatinosa, crosses over in the ventral white commissure, and then ascends as the spinothalamic tract. And on its way to the post-central gyrus, sorry about the typo there, it synapses in the VPL of the thalamus. And I thought it's worthwhile pointing out that it goes through the lateral medulla. Very important later when we talk about lateral medullary syndrome. Okay, the dorsal columns or the posterior columns, or sometimes called the dorsal column medial lemniscal pathway. So this is for vibration and proprioception. And arbitrarily, vibration and proprioception that comes in below T6 we call the fasciculus gracilis, and vibration and proprioception information above T6 is the fasciculus cuneatus. So practically, since we don't really think about vibration and proprioception in thoracic dermatomes, when we say fasciculus gracilis, think about the leg vibration and proprioception, and fasciculus cuneatus arm proprioception and vibration. And so when we get into the lower medulla, we have the synapse at the nucleus gracilis and cuneatus, and then the pathway crosses over here in the internal arcuate fibers. So very important, vibration proprioception crosses in the lower brainstem, pain and temperature crosses in the spinal cord. And that is how we can understand the Brown-Sequard syndrome, which we'll come to in a minute. After it crosses over, it becomes the medial lemniscus, synapses in the same thalamic nucleus VPL on its way to the post-central gyrus on the sensory cortex. All right, so a quick review of a little bit of anatomy there of the spinal cord. So most common spinal cord condition that we see is compression. And so here we have an obvious disc disease and herniation. So we lose that nice cushion around the spinal cord here with the subarachnoid space. And that's really obliterated here. And so the classic thing that we see with cord compression, the cord is small. So if you compress the cord, you tend to get swelling throughout the cord. And so you get upper motor neuron findings below the level of the lesion. So if we have a C5 compression, then the patient's going to have spastic weakness below that in the arms and in the legs. But at the level of the lesion, you compress nerve roots. So you're going to get focal radicular findings, pain if it's a C5, down the lateral shoulder with some numbness, and loss of reflexes in that distribution. So the biceps reflex, brachioradialis reflex, which are C5-6, would be diminished. So it's often the focal root problem that can tell you precisely which level of the cord is compressed. Anytime we have cord compression that involves the posterior columns, Lhermitte sign is common, and so this is most common in the cervical cord, where especially if the patient flexes their neck, they'll get this jolt of electricity that travels down the spine and into the legs. Bowel and bladder function is almost universal in significant spinal cord pathology, and in a little bit we'll talk about the importance of the acute atonic phase and then the more chronic spastic phase of urinary incontinence. And superficial abdominal reflexes, which are very difficult to elicit, are absent in cord compression because those are different than deep tendon reflexes. They have a cortical loop, so it has to go all the way up to the brain and then back down to contract the abdominal musculature. I only bring this up because it has shown up on a board question. It's hard to get these in normal individuals. You really need to have a thin individual to even appreciate abdominal reflexes in the first place. All right, so here we have, let's say, a disc. Okay, and so as it pushes on the cord, it's going to involve the corticospinal tract, and if there's a lot of edema, it may get the corticospinal tract on both sides. So we have spastic weakness below the level of the lesion. We're going to have loss of pain and temperature below the level of the lesion. Here's the spinothalamic tract. And we're going to have loss of vibration and proprioception below the level of the lesion. Okay, and at the level of the lesion, we're going to involve nerve roots. So again, focal lower motor neuron findings, focal loss of sensation in that dermatome. Okay, the Brown-Sequard syndrome would be one of the most commonly asked board questions for, I think, step 1 or step 2. And so the three pathways here that are most commonly involved, let's just say we have a hemisection here of the left half of the cord, and in orange we have the corticospinal tract. So we're going to have ipsilateral spastic weakness below the level of the lesion. Okay, here are the posterior columns. And so because this hasn't crossed over yet, this crosses in the lower brainstem, a lesion of one half of the spinal cord will result in ipsilateral loss of vibration and proprioception below the level of the lesion. But the key thing here is because pain and temperature is always crossing over at every level. So if we have a lesion right here, we're going to lose all pain and temperature on the opposite side of the body below the level of the lesion. So that is the crossed finding that we see with spinal cord lesions. And if you see that, the lesion can only be in the spinal cord. Okay, so let's kind of walk through a little bit here about anatomy of the bladder and to understand some of the clinical syndromes here. So as the bladder fills, okay, we get afferent information here that not really shown here, but through the pelvic nerve predominantly, that ascends the spinal cord, sort of just in the posterior columns or lateral to the posterior columns. And this activates the periaqueductal gray and then the prefrontal cortex. Okay? And so the brain becomes aware, so to speak, that the bladder is filling. Okay? Now, to understand what happens next, we just need to realize here that the sympathetics, which mainly come from the thoracic cord to the bladder, go through the hypogastric nerve, and the sympathetics want to prevent voiding. And so the sympathetics here will inhibit the detrusor muscle. Here's a beta-3 receptor, and it will contract the internal urethral sphincter. So both of these work together to inhibit voiding, whereas the parasympathetics, which we see here via the pelvic nerve, want to contract the detrusor muscle via these muscarinic receptors to stimulate voiding. And then we have what is under somatic or voluntary control here from these anterior horn cells called Onuf's nucleus in the sacral cord, and via the pudendal nerve and nicotinic receptors, these constrict the external urethral sphincter to prevent voiding. All right? And so when the brain decides, so to speak, to void, All right, what happens here is this originates in the prefrontal cortex. Later on I'll show you, but this is the medial part of the frontal lobe in the paracentral lobule. And from here the signal goes back to the periaqueductal gray in the midbrain, and then to the pontine micturition center, as the name indicates, in the pons. Okay, so what needs to happen then to void is we need a descending signal here to inhibit the sympathetics, and right, the sympathetics are trying to prevent voiding. So if we inhibit the sympathetics, we lose that inhibition on the detrusor muscle, we lose that constriction on the internal urethral sphincter, okay? And along with that, this descending pathway will activate the parasympathetics here. So now out through the pelvic nerve to stimulate these muscarinic receptors on the detrusor muscle so it contracts. And then also to this descending pathway inhibits Onuf's nucleus here and inhibits the pudendal nerve to the external urethral sphincter, so that sphincter opens. Okay, so again, the descending pathway as a big picture needs to inhibit the sympathetics, activate the parasympathetics, and inhibit the somatic motor neurons here through the pudendal nerve. Okay, so as a big picture, that's what happens as the bladder fills and we have voiding. Here's another way of looking at it. All right, so here let's just say the bladder is distending, filling. Okay, and so that activates the pelvic nerve. And what I couldn't really show you on the other diagram is that this filling, you don't want to just be voiding all the time, right? And so as the bladder fills, the pelvic nerve actually stimulates here these thoracic sympathetic neurons, okay, to then contract the external urethral sphincter and inhibit the detrusor. So here it is shown here. So again, via the pelvic nerve, the bladder is filling, and that ends up then actually stimulating the sympathetic nerves here, again, to prevent voiding, to constrict the internal urethral sphincter. Okay, at the same time as the bladder fills, we want to contract this external urethral sphincter until it's time to void. And so it stimulates these Onuf's anterior horn cells here, okay, so that we have constriction of the external urethral sphincter. And so again, once the decision is made to void, then the descending pathway from the pontine micturition center will do exactly the opposite. It will inhibit the sympathetics via the hypogastric nerve. It will inhibit Onuf's nucleus here and the external urethral sphincter, so it opens, and it will stimulate the parasympathetics here to via the pelvic nerve to activate the detrusor muscle. So that's what happens normally. Now, in pathologic conditions, we'll just, even though we're talking about the spinal cord, we'll just cover this briefly now. If you have lesions in the brain along the midline, in the paracentral lobule, then there isn't so much of a decision to void. When the bladder fills, there's just a reflex activation of the pontine micturition center. And so these patients lack voluntary control over voiding. And so when we see patients that have here a lot of atrophy, like someone with Alzheimer's disease, or maybe that someone that's had a lot of strokes involving the frontal lobe, any frontal lobe syndrome, we're going to see incontinence in that situation. And patients need to wear diapers often. Now, cord compression does two very different things with the bladder, and it's very important to be aware of the acute phase. So if we have an acute spinal cord trauma here with cord compression, then we get this spinal shock, and this results in a flaccid bladder. The detrusor muscle can't contract at all, but yet the urethral sphincter is still contracted. There's sort of it's out of sync. And so what happens then is the bladder can fill frequently to a dangerous degree, and patients try to go to the bathroom, they can't get much out. If you put a catheter in, they have a very high post-void residual. So if we see someone that is in acute cord trauma, we're typically just going to put in a catheter right away, because that can be very dangerous with the distension of the bladder and they can't empty it. Over time, we go from the atonic phase to the spastic phase, where now we do have kind of an overactive parasympathetic tone going out to the bladder, so it contracts, but it's not in sync with the urethral sphincters. So these patients have an urge incontinence, they're leaking urine, they can't empty their bladder fully, but they don't have the very high post-void residual here, because in this case we do have contraction to the detrusor muscle. And so for these patients, and I'll come back to the diagram to illustrate this, because of the parasympathetic overactivation, oxybutynin, which blocks those muscarinic receptors, can be helpful to relax the bladder and can help patients that have urge incontinence. Now, if we have a lower motor neuron lesion like of the cauda equina, or if we have compression of the sacral spinal cord, now we get a flaccid bladder because we're losing that parasympathetic outflow and also some of the sensory information coming from the bladder as it fills. And this is called an overflow incontinence, and patients have urinary leakage and also can't empty their bladder completely. So just to come back to the diagram here. So again, anything that affects the cord, but here we've got cord compression. So remember, acutely you get that flaccid atonic bladder. Over time, and again the really high post-void residual, over time we get a spastic bladder due to really you kind of lose inhibition on these sympathetic neurons here in the thoracic cord, and so we get now we get an overactive parasympathetic system. So this is why giving oxybutynin, which I pointed to sympathetic, but I meant to say parasympathetic here, overactivation of parasympathetic neurons here. And so giving oxybutynin here blocks these muscarinic receptors, relaxes the bladder, and again helps with urge incontinence. Okay, if we have our lesion down here, okay, now we lose parasympathetic constriction or contraction to the detrusor muscle, and so this leads to overflow incontinence. So you certainly wouldn't want to give oxybutynin to these patients. They already are not stimulating these muscarinic receptors enough. Okay, and this diagram just shows, of course, other issues. If we have a prostate hypertrophy, there we get a mechanical overflow incontinence, or we can have a stress incontinence, very common in women. Something else that's very common with anything that involves the spinal cord, above T6, is that we get this condition called autonomic dysreflexia. And so this is really a problem with an exaggerated activation of the sympathetic nervous system. Frequently, what I've seen most often is, these patients usually have a catheter because they can't empty their bladder. And so changing the catheter is often uncomfortable and may trigger this, or sometimes just bladder distension, not being able to empty the bladder can trigger it. Straining to have a bowel movement, anything that would cause pain, sometimes even sexual activity. And so you get this just a kind of a reflex activation of the sympathetic system. And so blood pressure goes up significantly. Patients have headache, they're sweating, they're anxious, and although you would expect them to just have tachycardia with activation of the sympathetic system, anytime you just bombard a nervous system like that, you can get a little bit of instability. So they can fluctuate between tachycardia and bradycardia. Here's just a nice drawing here that a student showed indicating some of the things that can trigger it. And above the lesion, we get really significant autonomic activation. Now, one thing that I think may be a frequent board question is if we have acute cord trauma. So someone has had, a motorcycle accident or something like that. And we've got here a big hematoma pushing on the cord. Give high-dose steroids to try to reduce inflammation and restore spinal cord function as soon as possible. And now, of course, we're going to, consider all the surgical options, but we'll give the patient a course of high-dose steroids after trauma. Medications which can help for spasticity. Again, this is an upper motor neuron condition, so we have increased tone, and so baclofen is a medication that acts on GABA receptors. GABA, recall, is an inhibitory neurotransmitter, so if we increase the activation of that in the spinal cord, it helps to relax muscles. This can be given orally or can be placed into the CSF via a intrathecal pump, which might be more effective than oral baclofen. We can also give benzodiazepines, which also act on GABA receptors, but these are quite sedating, and so that's why we'll try baclofen certainly first. And if there's more of a focal spasticity, like some muscles that are just really overcontracted, then we can do focal botulinum toxin injections to relieve the increased tone. All right, a couple unique spinal cord syndromes. If we have a lesion growing in the center of the cord, especially tumors, and the two intramedullary spinal cord tumors that would grow like this are ependymomas and astrocytomas. And they tend to grow out in this manner. So here I've shown one here growing from C5. And remember the columnar arrangement of the spinothalamic tract, where the cervical fibers are medial, then thoracic, and then lumbar. So if we have a tumor, like an astrocytoma, growing out like this, notice that the sacral fibers tend to be relatively preserved. And so this is called sacral sparing, where patients would lose pain and temperature quite diffusely from below C5, but they would have sparing of the sacral dermatomes. So if you see that the lesion is growing within the cord itself, it's probably a tumor. All right, something that acts quite differently is Syringomyelia, which is highly associated with Arnold-Chiari malformation type 1. And Arnold-Chiari, I'll talk about in a little bit in a subsequent lecture, but we have low-lying cerebellar tonsils, and that tends to promote this central cavitation of the spinal cord. This can also be caused by trauma or other things as well. And so the center of the cord, we just developed this cavity. And so in Syringomyelia, here we have this center of the cord. Now this is not a tumor, but a growing cavity. And these always tend to early on affect the crossing pain and temperature fibers. And so if the lesion starts at C5, the patient's going to have a loss of pain and temperature in the C5 dermatome in both arms, perfectly symmetrically, because notice both the sensory fibers from both arms are crossing over right here. As it extends down, in this case to C7, well, now the loss of pain and temperature is going to extend to C6, which is the thumb, and C7, which is digits 2, 3, and 4, again in both arms. So patients have lost pain and temperature, and so they're going to maybe burn their hands, or notice when they take a shower that they can't tell the temperature very well in that distribution. Now, as lesions extend out more laterally, and a big syrinx can grow, to involve this part of the cord, the patient may have upper motor neuron findings as well. If it grows up all the way into the medulla, which it can, then it can affect important areas in the medulla for swallowing, and in that case we call it syringobulbia, which is not very common. Okay, and I think national boards have been in a rut for the 20 years or so that I've been involved in teaching. The story is usually someone who is cooking and they keep burning their hands because they've lost pain and temperature. So if you get that story, they're probably going to ask you about syringomyelia. Now, if we have a spinal cord stroke that affects the anterior half of the cord, so this is supplied by the anterior spinal artery, then we're going to get an anterior spinal cord syndrome. So below the level of the lesion, the patient will have spastic weakness. Here's the corticospinal tract, and they'll have loss of pain and temperature. But notice the posterior columns are in a different vascular territory. Okay, this is the posterior spinal artery. So this patient would only have loss of, will have strength here in purple, loss of pain and temperature in green, but the posterior columns would be normal. And so because this is a stroke, stroke risk factors like diabetes and hypertension would be common. And there is a very important blood vessel here, the artery of Adam-Kavitz, which I can show here on this section. So remember that the blood supply to the spinal cord is boosted by these radicular arteries. Every nerve root has a radicular artery that travels along with it. But it turns out that only about 7 or 8 of these meaningfully contribute to blood supply to the spinal cord. The largest radicular artery we can see right here is the artery of Adam-Kavitz, which supplies the anterior spinal artery. And so this can be damaged just by vascular disease, or sometimes a patient is having a surgery on the aorta. Okay, and so there is, because it's such a large radicular artery, there's a watershed area, and so we can see strokes here in the mid or upper thoracic cord if we have involvement of the artery of Adam-Kavitz. Now, vitamin B12 deficiency tends to affect the posterior aspect of the cord. And so I mentioned this in peripheral neuropathy. So patients with B12 deficiency do have stocking glove sensory loss, but the major presentation of B12 deficiency is from the posterior column involvement. So the complaint these patients have is, "Doctor, I'm falling," because they don't know where their legs are in space. And you examine them and you find that they have a severe loss of vibration and proprioception. Now that demyelination does extend out here into the corticospinal tract, so they usually have some upper motor neuron findings, a Babinski sign, something like that. And out here in red, this indicates they also have a stocking glove peripheral neuropathy. So B12 deficiency, if you haven't heard of it or you haven't thought about it, you can't localize the lesion, right? Because they've got stocking glove, that's peripheral nerve. They've got loss of vibration proprioception. They've got upper motor neuron findings. So this is why it's called subacute combined degeneration. But I would just say anytime you see a patient with severe loss of vibration proprioception that's coming on over, a long period of time, always check a B12 level. And if you do an MRI, here we can see this demyelination here of the posterior columns in B12 deficiency. Now, tabes dorsalis or tertiary neurosyphilis is something that we would mainly see in the HIV population related to syphilis. And like B12, they have a progressive posterior spinal cord syndrome, so they're falling. But this also tends to involve the dorsal nerve roots. And so like any radiculopathy, there's pain, there's back pain, there's shooting pain down the leg. These patients don't tend to have upper motor neuron findings like you would see in B12 deficiency. Okay, and the counterpoint to anterior spinal artery stroke is you can have a stroke with a posterior spinal artery. And again, these are strokes, so they come on suddenly, and your exam in this case will reveal, the patient's falling, but it's not because of weakness. It's because they have no vibration and proprioception sense below the level of the lesion. But the rest of your exam will be normal. All right, so we're going to add to this causes of gait instability, but I just wanted to add that anytime we have a severe loss of vibration and proprioception, that will often present with a what's sometimes called a stomping gait. So the patient has a sensory ataxia, that's another name for it. It's not a cerebellar problem, but they don't know where their feet are. So we'll sometimes call that a sensory ataxia. But they're trying to get some proprioception sensation up to the brain, so they often will stomp loudly, which helps to get just a little bit of sense to the brain about where the feet are in space. Okay, we've already talked about a steppage gait due to a foot drop in perineal neuropathy and L5 radiculopathy, and we'll come to these other gait disorders later on. finally, let's just talk a little bit about some normal physiology, which is probably most pertinent to step one, probably less likely to be asked about this for anything after step one. So remember that in the muscle here, when we say the muscle, we're talking about these extrafusal muscle fibers. So if this is the quadriceps muscle, the the femoral nerve is going to supply the muscle. But in parallel, we have these intrafusal muscle fibers. Okay, these are contractile elements here, but these aren't responsible for moving the muscle and not giving us strength, that kind of a thing. But rather, here in these intrafusal fibers, we can see there are nuclear bag and nuclear chain fibers. And there are two types of nuclear bag fibers, but the ones you need to know about is these nuclear bag dynamic fibers. And these are the ones that are activated by a rapid stretch, like when you check your reflexes. You tap on the tendon, you get a brief stretch of the muscle. Well, that's stretching these nuclear bag fibers, and we get these very fast, mainly group 1A afferents that send that information back to the spinal cord. Okay, and in just a minute I'm going to talk about the importance of these gamma motor neurons, which are activating the muscle spindle. Okay, so here we tap on the patellar reflex, which stretches the muscle spindle. Okay, and so we get this very rapid signal that goes directly monosynaptic right to an anterior horn cell here, which is going to go right back to the quadriceps muscle, and so it contracts and the leg kicks out. Okay, but via an interneuron, you also activate to inhibit here an anterior horn cell that will inhibit the hamstring muscles. So that's called reciprocal inhibition. You activate the agonist, in this case the quadriceps, you inhibit the antagonist, in this case the hamstrings. Now, what do the gamma motor neurons do? Here are the gamma motor neurons, and these are very important. So here's an anterior horn cell or an alpha motor neuron talking to the extrafusal muscle fibers, and our gamma motor neurons are located right adjacent to that, and they are activating the muscle spindle. And so to understand what gamma motor neurons do, so here we have the extrafusal, the bulk of the muscle. Here we have the intrafusal or the muscle spindle. Okay, it's supplied by gamma motor neurons. The extrafusal muscle is supplied by anterior horn cells via peripheral nerves. Okay, so let's just say this is the biceps and you contract your biceps. So it's anterior horn cells sending a signal here to contract the biceps. And so this middle diagram is kind of a theoretical thought experiment to show you what would happen without gamma motor neurons. When you contract the muscle here, well, notice that the muscle spindle is going to get kind of squashed flat. Okay, why isn't that good? Well, what do muscle spindles do? They respond to quick stretch. So if you were to stretch your biceps quickly in this contracted position, nothing's going to happen. The muscle spindle is not in a position, needs to be tight in order to sense that stretch. And so every time you contract a muscle, okay, the gamma motor neurons, now here we can see activation, need to contract in parallel. Okay, so now your biceps is contracted and the gamma motor neurons have contracted your muscle spindle. Okay, that's called co-activation of alpha and gamma motor neurons. And now, even in the contracted state, if your biceps were to stretch a little bit, now the muscle spindle would be in a position to detect that stretch and to appropriately alert your spinal cord about any stretch movement in that muscle. Okay, so we need those gamma motor neurons so that with any type of movement, it can always be very precise and accurate. Now, another thing you need to know about are the Golgi tendon organs, which occur here at the junction between muscles and tendons. Okay, so here's a Golgi tendon organ. So again, let's say if we contract the biceps, we activate the Golgi tendon organ, which does something that at first glance seems counterintuitive. So it's activated because of the contracted muscle, and what happens is through an interneuron, it actually goes back to inhibit the agonist, in this case the biceps, and to activate the antagonist, in this case the triceps. Okay, why would you want to inhibit a muscle that you're trying to contract? The main reason is that, just think about anything, a very fine activity that you do, like writing with a pencil, or think of a surgeon, doing surgery. You frequently need to activate agonists and antagonists together in parallel so that you can make a very precise movement. And so the function here of Golgi tendon organs, which unlike muscle spindles, which are mainly responsive to stretch, Golgi tendon organs are more responsive to the state of contraction or tension in a muscle. And so it allows the brain and the higher pathways, which I can't really show here, to sort of use all of these neurons and these circuits here to very precisely manipulate them for any type of movement. All right, but we need to be able to contract agonists and antagonists frequently at the same time for precision of movement. All right, something else to know about here is the crossed flexor extensor reflex. And so imagine here stepping on a tack. What would you want to do? Well, you'd want to flex the hamstrings, right, which is going to flex your knee, and you'd want to relax your quadriceps, right? You don't want to activate that and step into the tack. All right, so when you step into a tack, that information goes up. And notice everything is through interneurons here in the spinal cord except for the muscle stretch reflex. That's the only one that's a monosynaptic connection. So via an interneuron here, this then is going to contract the flexor and inhibit or relax the extensor muscle so the leg draws away. Okay? But if you do that, you're going to fall over unless we have information that crosses over to the opposite side of the spinal cord to do exactly the opposite, which is now to activate the extensor and to inhibit the hamstring so that your leg straightens out. So you balance on the opposite leg. So, how often do you step on a tack? Not very often. What actually is more practical understanding of this is the circuit that's involved with every step that you take, where you are doing exactly the opposite thing in both legs, whether you're stepping on one leg and then stepping on the other leg. So the flexed crossed extensor reflex here is really just showing the normal physiology of walking in terms of spinal cord circuitry. So a couple last things here on the spinal cord. This is a section of the thoracic cord. How do we know? Because a very, very small ventral horn, very few anterior horn cells. And notice that here we have the intramedullary cell column, these sympathetics, which travel through the thoracic cord. Okay, so that's unique in the thoracic cord. And also our Clark's nucleus is right in this location. Okay, so again, this will become the dorsal spinocerebellar tract, which we'll talk about when we get to the spinal cord.